Yeah, Saibal, and I certainly agree with your last comment. I was going to open with that, so you were very clever. I was going to say that when you're debating your mentees on stages like this, then that really, I think, says something about that you've done a job well done, because obviously Joanna deserves to be up here. And frankly, I've been trying to prepare because she's very good at this stuff. So I'm hyped she's going to remember I'm older than her. What's that thing, Michael? Respect your elders. You've said that before.
She's one of the legends of this meeting.
This guy should go into politics. He's setting the expectations exactly right.
She was invited as a legend.
The other thing I'll say, because we've been a little relaxed with the clock. Thanks for 5 whole minutes for this very interesting topic. But I'm going to take an extra 20 seconds to tell Saibal, like I told you at lunch, if you keep lowering the bar for the endpoints for these trials, maybe I will try a MitraClip. I probably could get away with it. Okay, so at any rate, what we're going to talk about is a really important topic, and that's about the endpoints for these TEER trials. What I don't want is what happened with all this CABG stuff that happened a year ago, Greg. I don't want to have the conversation after the trials are done, and I want to talk about it now, not later when they're published. And this is such an important topic, and I'll start with my disclosures. I've been invented a lot of different annuloplasty rings that are used around the world. But I've also been the national co-PI of 3 different structural trials. I'm not defending surgery. I'm supporting patients. Remember that. I'm not trying to defend one side or the other. That's why I've been involved in 3 pivotal trials. But we really have to defend patients, and that's what I'm going to do in my 5 minutes. I want you guys to look at that word contentious. Here's the definition: likely to cause disagreements and arguments, perverse and wearisome tendencies to quarrel and have disputes. In all my time in those 3 pivotal trials, I have never seen that word used once to describe one interaction with my multidisciplinary group. Michael, ever? Have you? We've done 2 of them together. I've never. Everything is never, there's been nothing contentious about it. It's about a trial, the design, and the patient. Nothing contentious. Well, I decided to show some emails. This stuff's going around. This isn't a secret. This is a big group of people that care about this field. And I'll show you a couple of thoughts about it to really make an impression. Looking at Roxana's face, I can see I've got her attention. Here's what I wrote 2 days ago, getting ready for this talk. I was just taking a look at this email trail, preparing for a mini debate I have them with Joe later this week. I still don't know how this is contentious. Okay, it is contentious. Let's don't kid ourselves. There's no agreement on this topic yet. What's contentious? Well, I highlighted it in yellow for you in both the ongoing TEER trials and degenerative disease. It's this business of moderate MR being an acceptable outcome in prolapse. I'm sorry, that's really a problem for a lot of us that have spent our careers taking care of patients with mitral valve disease. And I've talked to Bob. It's a problem with some of the cognitive cardiologists out there too. They don't send their patients to us for moderate MR to come back with moderate MR. And you can see both these trials. One of them says moderate or less than or equal to 2+. The other one, you're free from 3+ or greater. I think the new phrase is freedom from 3 or 4+ MR is the success point. I don't think so. Why do I say that? Because I've spent a career trying to get to mild or less MR. And why? This paper had such an influence on me back in 2005. This was the reason that we started doing degenerative patients, by the way. It was Serrano's paper. But don't kid yourself. Look at the middle curve. That's the moderate MR curve on each one of these figures. So if you're asymptomatic and you're waiting for surgery, your survival is impacted by moderate MR. How about after surgery? Well, there are many papers to show that. This was the one that, again, had the biggest impact on me, which was the Mayo Clinic talking about the impact of residual MR on reoperation. We were all, back then, Michael will remember, we were accepting a little bit of MR. We got rid of a lot of it. It sounded a little bit like the discussion we were having an hour ago on that TEER case. MR is bad, and it predicts bad things in surgery, and it won't be any difference if we wait long enough. Here's a little bit more of the recent literature. This is a paper that basically looked at Octavio Alfieri's and Marciano's data in transcatheter or surgical treatment in elderly patients with degenerative disease. I'll just highlight the two things I think are relevant to this discussion. So look what the impact of MR recurrence to 3+ or greater was on survival. I can tell you I don't want 3+ MR. What was the greatest predictor of 3+ MR? I want you to look at that odds ratio. Residual 2+ MR. So how in the world did we get to a point where we say, it's okay if we do something to a patient and we have 2+ MR? It's not. It's not the right endpoint. Greg and I were talking about this at lunch too, about COAPT trial. And Greg's right. What matters is you don't have 3 or 4+ MR. But I know one thing. I know which curve I want to be on. I'll take green in terms of mortality or heart failure. You can tell me, yeah, but it's only 8% difference. Well, you know, we get chemotherapy for 8% difference. So don't forget, moderate MR does matter. And here's the TVT registry data. The 1.0, that's your 2+ MR. That's your moderate MR. I know I want to be that little blue dot on the side that says low. That's grade 1 or none. So we've got to get to 1+ MR. Doesn't matter what group you look at. Now here's the TVT data on case counts versus getting to 1+ or less. And what you can see, you got to do a lot of cases to get to the sort of 80% point. And I know there are more clips and there's more experience, and these trials are going to be very carefully selected, not the general population. But you know, don't be surprised by that. I'll remind you that in the Everest trial, and surgery didn't change that much the last 7 years. In the Everest 2 trial, 20% of patients had 2+ MR at 6 months. So, you know, it's a fair fight, but we don't have to lower the bar to get there. And this was data we saw before between Pascal and MitraClip in this CLAPS trial. And again, same kind of number. It's not 0 2+ MR. It's a significant number of patients. So again, we have to be very careful when we move it to 2+. Like I said, maybe I'll start doing the clips with no experience because it looks like you can get there. The question is, should that really be what our goal is, particularly as we move into low-risk patients, which one of these trials has done. And this is a paper that Joanna was the lead author on that I was involved in, looking at what happens after MitraClip. If you have a failed MitraClip, well, there were a couple of things that happened. One, probably the most shocking thing in this paper, and I didn't bother to show it because we don't know what the patients were, but the O to E in the STS mortality risk model was 1.6, 1.57. Have you ever heard of that before? An O to E almost 1.5 times what the predicted risk was. The failure of a MitraClip is not benign. It's actually important. And look at the replacement rate, 95%. Please don't tell a low-risk degenerative patient, don't worry, you can always get a repair. That's not true. It's not true. You'll get a replacement, and it will impact your survival. And Greg, I was honored to be on this document with you, which was the MPARC endpoint document. And I just show you the definitions. Yeah, and by the way, this wasn't contentious. We all agreed. We had to have the optimal idea. That's 1+ or less. Then we were going to have the acceptable one. Why did we have the acceptable? We had a long discussion about it. I didn't change my genes in 5 years with the knowledge. We had a long discussion. We did that because there are going to be certain patients where we'll take it. Show me an 80-year-old, a re-op, bad candidate, hospital. You give me a patient, I can tell you I'll accept 2+ MR. I'm just not going to do it as we move into low-risk patients. And this paper really says it all to me. Many of the authors on this are currently involved in our ongoing TEER trials. And many of these patients are involved in our ongoing, many of these authors are involved in our ongoing TEER trials. This is 2020 JAMA Cardiology, and I'll just read you one of the measures here I want you to focus on. Rate of successful mitral valve repair of primary MR, residual mitral regurgitation grade of mild or better. That would mean less. What changed in 2020? Many of these surgeons are on these papers. That's the definition of a successful valve repair. It's not 2+, and I don't care who meets in what room, it's not 2+, it's 1+. And I'll just go back to the emails to finish up. This was an email I sent to this group. I agree with someone's point about the patient not defending a specialty, surgery intervention. We're not defending surgery, we're defending these patients. Having said that, I honestly have not met the patient or referring cardiologist that thinks freedom from 3+ to 4+ MR is the goal of a mitral valve repair in a low-risk setting. It's not 2+, it's 1+. And at the end, I said lowering the bar for all patients, which is exactly what will happen in the real world as a result of redefining successive mitral valve intervention. Surgery or TEER is not going to help the degenerative field. And that's my argument about these endpoints. You can see I go back to contentious. As we all know, this has been a contentious discussion. It's clear that most patients in the NIH trial will be low risk. Virtually all surgeons oppose moderate MR as an endpoint. So yes, we need this discussion because we really need to figure it out. And I like the end. This is best for the patients, and the reason we push for appropriate endpoints. And I'll just tell you, I asked at the end of my email, is there any progress on the low-risk trial since all these discussions started? And look who I heard back from. Dr. Chikwi a few days ago. Steady progress in the right direction. Looking forward to seeing you in New York. Joe, I turn the podium to you.